Good morning, everyone. I have the pleasure to chair this session this morning that is dedicated to personalized mycology and onychomycosis. We have 4 talks. We'll proceed with all lectures, and at the end, we'll have a small session of question and answers. I invite now Daniela Dobrosavievich-Vukojevic to present her talk about the role of personalization and severity index scores in patients suspected with onychomycosis. Please.
Good morning. Thank you for your kind. I would like to thank the organizer for inviting me to this call for this meeting. And my talk is to speak about the role of personalization and severity index score in patients with onychomycosis. So this clinical image is a very advanced clinical image of the disease that lasts for a long time. As a dermatologist involved in the treatment of this kind of disease, I know how hard it is to treat and sometimes impossible to treat the patient and sometimes impossible to cure. So this is a fungal infection of the male unit caused by dermatophytes, non-dermatophyte molds, and yeasts. So it's the most common nail infection encountered in clinical practice. This is what we see literally every day. So the prevalence is usually 5.5 to 14% in the general population, according to the statistics in the US. However, it could be even 24% in the Europe. So almost quarter of the general population. So the prevalence increases with age. Therefore, we have the patients that are older than 70 years old, and half of them, literally half of them, do have onychomycosis. So we do have even children, so 0.5%, that are affected with this condition. So the most of them, the majority are dermatophytes, and in Europe, this are Trichopitheum rubrum and Metagraphites. The specific nail anatomy is very important for understanding the clinical presentation, the persistence of fungal infection, and the treatment problems we do have. Also, the problems in detection in the isolation of the yeasts. When we see the clinical image, we have to deal with 2 main fields of in anamnesis. That is, first is the patient itself and his or her risk factors, which means we do have factors that do belong to the patient, like does he or she has already tinea on the foot, like psoriasis, which is predisposing factor to all kinds of tinea, or hyperhidrosis, which is, let's say, very common condition. Then comorbidities are also a very important factor, like diabetes. Diabetes is top 1, the first place. However, immunosuppression, which is very common nowadays, not only HIV infection, this is rare, of course, but chemotherapy, which is very frequent today, transplanted patients and patients on dialysis are also affected. So if we do have venous insufficiency, which is also very frequent in general population, we do have a patient that with treatment or her treatment could be very difficult. Malignancies of all kinds, peripheral artery disease, obesity, and inflammatory bowel disease. Inflammatory bowel disease patients nowadays very frequently very frequently have biologics or biological therapy, which sometimes favor these fungal infections. Exogenous trauma, poor nail grooming, like all kinds of sports activities, like smoking and occlusive shoes. Do wear good shoes. That is always advised. So the problem is also that all kind of predispositions advance with age. If we do have some genetic problems, that nails are involved in the clinical pictures, and also some orthopedic conditions and contact with some other members of the household who do have also fungal infections. So we have a family reservoirs of these infections. So this is what the clinician has the problem in real life, in the practice, when we encounter patients with onychomycosis. And this is very frequent nowadays. And the reason why we are going to have more and more onychomycosis patients, so nail, manicure, pedicure, and UV lamps, they completely destroy the nail plate, thus having it perfect for invasion of the fungus. And fungus itself is a separate predictive factor because the fungus is capable of forming a biofilm. So, and now we have a problem in clinical in everyday life because 30 to 40% of all onychomycosis are caused by non-dermatophyte molds and yeast. Sometimes, believe me, it is impossible to treat and impossible to cure. So we have not only a problem in epidemiological sphere, but also in social sphere because the patients are hiding um, um, they're hiding their hands or nails, and therefore we do have even that social component. So here are the most clinical images we do encounter. Sometimes the clinicians don't have the time. For instance, if it's not a dermatologist, I'm a dermatologist. I know how important it is, and we always do. So this is superficial white onychomycosis. It's a good news that it's easier to treat because it is superficially, but it can last for years and forever if untreated. So this is the distal onychomycosis. These are our patients from our project. So we have a lot of images, but these are just a couple of them that I chose for this morning. The distal onychomycosis affects only distal edge of the nail, but it's good news that it's still good to treat, and we have a very successful cure rates. So it's good news. Now we have distal and lateral onychomycosis, meaning that it has a distal part, but also coming to the nail groove, so the lateral part. This is then bad news because lateral involvement and the involvement of the nail matrix, the live part of the nail plate, is difficult to treat. So this is proximal white onychomycosis. This is bad news. How we know is it hard to treat? Because in this case, the proximal part, the live part, the matrix involved. Whenever we do have matrix involved, it is impossible to treat the patient only with topics. So we have to use systemic plus topical therapy. So when we have proximal white onychomycosis, we say, oh, this is bad news. Total dystrophic onychomycosis is very frequent nowadays, and there are doctors that they see, but they don't see it. A dermatologist always see that because usually total dystrophic onychomycosis is more than 2 millimeters thick, and it's very hard to treat. So we have to always employ systemic plus local therapy. If we have a patient that is old, that have a lot of comorbidities, a lot of medications in everyday therapy, it is impossible to treat. And what is good to do in the clinical practice, to give some kind of topical anti-fungal medications in order to keep them to be there, not to go further and not to destroy the nail plate and the surrounding skin with inflammation. You see, this lady is, having manicure of her nails every day or during her life. However, she was also having manicure of her fungal infected nails, which have total dystrophy onychomycosis. And we can say that this condition lasts for more than a year because two nails grow for 1 year, at least 1 year. So we do know that this condition lasts for 1 year. So you see, the nail plate is thick, more than 2 millimeters. It has yellowish and greenish component. Sometimes could be mixed with bacterial infection, which makes the story more serious. So how do we know how hard or how big the clinical picture is, how hard it is to treat? Because, of course, there is a scoring system. The one we usually employ, the one I usually employ, the one we employed in our project is also onychomycosis severity index score, which encompasses patient's characteristic, nail characteristics, for instance, among hyperkeratosis, significant lateral disease. So we have dermatophytoma, like a streak or a patch. You can see the dermatophytoma here, like, let me see, it works. So this is the dermatophytoma. This is a collection of fungal elements in the nail plate. So when you take this, it's pure culture. So dermatophytoma is a bad sign. And dermatophytoma is always much better if it doesn't involve the nail matrix. So this is the nail matrix. So you see, divide the nail plate in 1, 2, 3, 4 portions, and separately we inspect the nail matrix. This is the fifth, the worst. So the more distant from the nail matrix, the better prognosis is. And dermatophytoma is here. So this is the pure fungal culture, in the nail plate. So this is a bad sign, of course. So there are scoring systems, for instance, number of points, percentage of the nail infected, amount evolving from the distal edge, and if dermatophytoma or subungual hyperkeratosis more than 2 millimeters is employed. So no, yes. So we have a scoring system. So in practice, it looks like this. We do have OC score 1 to 5. So this is considered to be mild. So this is good. This is distal infection. So it's good to treat. It's easy to treat this patient. However, we do have this distal and lateral component. Here we do have a moderate score from 6 to 15 points. And here we have total dystrophy of the nail. So this is 16 to 35. In this case, 35 points. So this is severe. It's hard to treat. It's not easy to treat the patients. So we do have treatment options. If we have a small affected area, 1 to 3 nails is good. We can have the topical medications. But it lasts long, 6 to 12 months, because the nail is growing. If we speak about toenail, of course, which is the most clinical scenario, we have to employ it for 12 months, because this is the time for the healthy nail plate to grow. So it's more expensive than systemic, but it is impossible to avoid. Systemic therapy is employed, but it is contraindicated in liver disease. So in liver patients, you cannot treat, you cannot cure the patient if he or she has total dystrophy, for instance. And it is always applied if more than 3 nails are affected, and more than 60% of the nails are affected, and the nail matrix is involved. So we do have clinical parameters in order to decide how can we treat our patients. If we have older patients, if we have total nail dystrophy, vascular insufficiency, it is almost, onychomycosis is almost incurable. But the patient itself is reservoir not for his household, but for the general population if visiting, for instance, some bars, some other social, let's say, circumstances. So mold or mold plus dermatophyte infections are still challenging because I think we know that there are no effective cure, especially in this case. These are the data from large national commercial laboratory in the United States. And for instance, if you have two nails, non-dermatophyte molds, we find in 1/3. However, dermatophytes are 24%. So we see that the recent data show that non-dermatophyte molds are increasing, or at least we are more and more able to detect them. And yeasts, they are about 47.5% in the isolates. So you see, this is the March the 20th. You know what happened then? COVID. So the patients decreased in coming to see what is wrong with them, to have the swabs, so to less than 1/4. And so the whole 2021st year, so actually the COVID did not affect the patient themselves, but well, made the treatment of them very, very difficult. Artificial intelligence in the diagnosis, so it is, let's say, we talk about that, but my personal opinion that the artificial intelligence is still far behind the clinicians. So what do we have? We have a patient who has to first go to see the doctor. So has to have appointment. In some countries, it's not easy, so they have to pay. So it's the high cost of that examination. The patients usually have no time for laboratory sample. You have to go there and take the lab sample. Social restrictions, we saw what COVID did and what maybe, I don't want to say 100 years, but any future pandemic could do. And also reference laboratories too far. He or she has to go too far to have more and more time spent. So the idea of the project, Fungal Case Finder, is to, let's say, overcome all these problems. And this is the tool that the patient itself has to apply. The doctors, on the other side, doctors, we in white coats, sometimes do not have time for detailed explanation. Some patients do not understand. Written instructions are insufficient because I do it myself. I print it because the hospital doesn't have it. Inadequate sampling tools, sometimes, I don't want to say what I saw. No time for risk stratification. How important or how the patient has more or less risk. We do not have time for. And we do not do it. But in the States, for instance, 40%, according to the statistic, 40% of the patients in the States do have systemic therapy employed, but without lab confirmation. What do we treat? Do we treat onychomycosis? Do we dermatophyte mold yeast? What do we treat? What a combination. So these are the problems that could be also overcome by Fungal Case Finder. So this is a problem in everyday life and how to overcome the problem. So this project is also employing a software which is let's say, already deployed, and the patient easy to perform platform also for the doctors. So the patient himself or herself is able to, via the diagnostic tool, able to have the self-sampling and send it to the laboratory. This is the future. And also, not only that, all kind of materials, video materials, websites, the patient can see how he or she could do the sampling and how to prepare for it. So this is complete instruction. So the software has expert and patient software. So I don't want to talk about too much about that, but these are the necessary, let's say, notes that we always have to do. This is the Onychomycosis platform, and we always select each nail that is affected, 1, 2, 3, so we now know which is which. And also if the onychomycosis is on the hands. So this is the start. And then the results are that our patients were about 41 years old, and less than 40% were smokers. And we identified that about 40% were let's say, involved with the onychomycosis, and the fungal cultures were positive in about 24.5%. And we have to say that in our series of patients, these were detected in 80%, that the molds were more prevalent than in the average statistics. So it's about 60%. Is it about the fungal case finder? Is it about the sampling tool? Is it about the patients that are coming? So we have to see that actually we need larger data, larger. So here are the, let's say, infections that we detected, molds and mixed infections. Mixed infections were with Candida trichosporum most frequent, and Candida glabrata plus Aspergillus flavus. But from the perspective of a clinician, I'm the clinician. This is bad news. This is bad news, and the more and more we are going to detect that, which we don't like. So this is the interface of the, let's say, the fungal case finder. So in conclusion, we have to know that the personalization of the risk factors of the patient, the clinical picture. So this is the personalization. So it must be interactive process, patient risk stratification, and fungal isolation. So isolation is to be insisted on. I do not think that like the statistics in the US, that 40% of the patient do have systemic therapy without laboratory confirmation. I mean, this is impossible, and we in Europe, and at least in Serbia, do not do like that. So the self-sampling is the future. Sampling tool sampling was adjusted during this project, and what other data that are showing us that we do the right thing, because according to the statistics in the world, mixed infections and those caused by non-dermatological molds are more prevalent than we previously thought. Then this means that we have bigger problems than we thought. So a multidisciplinary team was involved: microbiologists, dentists, gynecologists, dermatologists, and statisticians, and who knows who else in the future. Thank you for listening.
Thank you so much for this overview about clinical and therapeutical aspects. And thank you for underlying the non-dermatophytic etiology of onychomycosis. That's a good topic to discuss. Thank you.
Thank you so much.
We move to the next presenter, and I invite now Snezana Minic to present clinical spectrum of dermatomycosis and onychomycosis therapeutic principles and problems.
Well, hello everybody. Thank you for inviting me over to be a speaker at this meeting. I do apologize, I'm not able to stand because of vertigo and I have to sit. So, but you will hear me, I'm pretty much sure about that. Oh, sorry. Let me close this session. And now,
Oh, I have to say that I'm sorry. This is Valentina because this happened to these are us. So we're like kids, every day like kids. So these are us. So I didn't do it. I didn't do it.
second. Okay, here we are. Well, hello again. I had a task to present, like what we see at our. Oh, sorry. Oh, yeah, sure. Yeah,
Thank you.
yeah, thank you. Not only the vertigo and clumsy. Okay, the spectrum of onychomycosis and well, dermatomycoses, so everything dealing with fungus in our clinic or everyday practice, better to say. So let me see how does it function. Here we are. We're talking about epidemiology. You already heard about nails, but we also think about skin itself, about hair infection, all that we call superficial mycosis, but then of course you have the prevalent worldwide dermatophytes, and of course the ones that are special for certain areas, and more prevalent in rural areas, what is also a special field of interest. And you have here some statistics. I'm not going to read them. I never read what I have on my slide. I do make comments. So we have a classification that we can make in different ways concerning the fungus. It could be how deep they go with their invasion, like superficial fungal infections, and that's what we have. And then we have also invasive fungal infections, which go deep. Dermatophytes are classified into three genera, as you can see: Trichophyton, Microsporum, Epidermophyton. And then the most important thing is to bear in mind that these fungi are keratinophile, meaning that they love keratin, tissues such as skin, hair, and nails. And that's why they stay there, and that's why we discuss this topic concerning these sites of the body. Then another type of classification, or another three types of classification, are depending on the depth, how deep they go. Are they superficial or they're deep? The origin, the causative fungi, and location. More or less, when we say tina, okay, women, then we can say profunda or superficial. And then, of course, we can also add the type. So in some ways, when giving diagnosis, we do actually cover all these three types of subdivision of types, which is quite handy, especially for the ones who are not in everyday practice dealing with these things. So superficial fungal infections affect only the outer layers of the skin, hair, or nails. Deeper ones are the ones that they go like hair folliculus, deeper into the skin, subcutaneous tissue. And the best examples for these are the ones that we see most likely are the carrion, and Mayoki granuloma. Anthropophilic tinea infections are the ones that are transferred from person to person among humans, and they're sort of least severe. Slightly more severe are the zoophilic types of infection, which transfer from animals to people. And usually we're talking about domestic animals. So therefore, if you have your pet animal, or if you're working in a farm or as a vet, there are very good chances that if the animals are infected, you may get the same kind of infection. Geophilic tinea infections are quite tricky ones to detect and quite tricky to treat, but they're not as frequent as the previous two. And this is it, the classification according to the location. I'm certainly not going to read this. This is just an example for you to flash your mind. How do we make diagnosis? Of course, the most important thing I would say still is direct microscopic examination with potassium hydroxide. And then we decide yes or no. We do that 3 times and so on and so on. And if we find spores or mycelium, we are certain that there is an infection of this type. How lucky we'll be with cultures, we'll see. Quite a number of cultures don't grow, but it doesn't mean that there weren't spores of mycelium. Histopathology with special dyes, PCR or MALDI-TOF. And here is how it looks like. So it looks a little bit drastic for those who didn't see it, but unless you do the good sampling, you have to really scratch it thoroughly, although it sometimes is unpleasant. Otherwise, you will have the false negative result. So you should do it in a proper way. Take the good sample, add a little bit of potassium hydroxide, and then you will see, as we may say literally in black and white, what do we have here? Cultures. I already mentioned we are not very lucky with cultures, no matter how cautious we are. Sometimes 30% can be negative, but then we shouldn't really decide not to treat these people. And then, of course, wood lamp. Wood lamp, under the wood lamp, you have this special shining color in different colors depending on the species that you're discovering. Then we have tinea capitis, affect the scalp, hair shafts, primarily seen in children because we don't have in children this sebum protection, therefore they're more susceptible to this. And then which one is the most common one? I would say this Microsporum canis, and it says by its name, usually transmitted from dogs or cats. And well, that's the one that we most likely see. Other species we can see as well. Then there is if we don't treat the tinea of the scalp, it may result in complete loss of the hair on affected side. That means cicatricial alopecia. It's not life-threatening condition, but it's certainly not nice. And then we have here the example, and we have this, again, subdivisions like non-inflammatory forms, anthropophilic, of course. They're always softer, I would say, than the one which are zoophilic, and not to mention that. So we have this gray patch tinea or black dot tinea, and then, of course, carrion and phallus. In certain areas of the world, or I would say Europe, it has been eradicated. But you never know. It may wait for its moment. And of course, there are certain areas in the world in which it's still giving you a lot of trouble. Preventive measure is hair cutting or shaving. Even shaving is necessary sometimes. Why? You have to see how much of the scalp is affected. You can't really, look in a bushy hair where it is and where it isn't. And of course, the presence of the hair can diminish the efficiency of the therapy. So, okay, you explain. Either you may have the problem of losing completely hair on some sites, Or you should cut your hair for a certain period of time, treat your scalp, and there you are, you're cured. Topical antifungal creams or shampoos, miconazole local treatment, and of course we have antifungal treatment which is oral. Griselfulvin is still number one on the top of the list. Unfortunately, for instance, we have the problem here in this country that it's not available, so we have to rely on itraconazole, terbinafine, and fluconazole. Then we have something, there could be certain resemblance of the situation of the scalp when we talk about beard, and of course we are that attributing to men. But this is a combination of he has tinea, or facial tinea, and especially the ones more on the side where he has beard. So you again have follicula. So quite often we have this comparison in treatment, especially local treatment, or even the oral treatment with the one with carrier. Then we have tinea corporis, which can be solitary, or it could be disseminated, depending on how quickly people recognize that they may have a problem. It usually itches, so they may spread it from one side to another, and there you have spreading of it. And then, of course, the hairy side, such as in the middle of this man, could be a good reason for this to stay there and spread hairs. I mean, they can go deeper. Yeah. Tinea corporis. Where is this? What are the conditions that facilitate this kind of infection? Of course, excessive heat, humid, warm, and dark. That's what fungus really like. So therefore, if we have heat, humidity, clothing, that means dark, beautiful, extremely good conditions for the fungus to grow. Zoophilic infections, of course, as I said, through the pet animals usually, or for domestic animals. Domestic population, vulnerable population among the general population are the ones who are immune suppressed, either by medications that they're receiving or because of the fact that they may be HIV positive. Myotic granuloma is a special type of tinea corporis folliculitis, and it goes deeper. It requires, of course, your therapy. Preventive measures as to wear light, what would say organic, that means cotton or linen or something, light, the clothing, not synthetics. And that especially goes for the gyms, because nowadays all these what nanotechnology what offers for those who are in gyms is using synthetic materials, and they facilitate this kind of problem. What do we have as for the topical therapy? You may read the list: clotrimazole, conazole, and blah blah blah. How do we use this? On the clean skin. Sometimes you have to stress this. They have to clean their skin first and then to apply the cream once or twice a day. Once is more or less okay. If they can make it twice, yes, but don't put it unless you wash yourself or the site on which you're putting the cream. Because they think literally it's important to put it twice, even on the wet, dirty skin. No, please, no. Systemic therapy. Here we are with what is offered, depending on the, it also, you have always guidelines, but then you always have experience of the therapist. And then you decide either to combine two or to rely only on local therapy. And of course, this is a very, very common condition, tinea cruris. And of course, as you see, the underwear of these two gentlemen, synthetic, it looks already dirty and awful. Wearing shorts, which are made of nylon, not washing themselves often, and of course, in elderly more present, but also in athletes. And it's quite often recurrent. Why? Because they carry on living in the same way, in the same manner, and they simply think, okay, this is it, I've cured it, and that's for good. No, it's an infection like the flu. If you give the good conditions for the yeast to grow, it will grow back. These are the conditions which I already mentioned. And of course, besides this, you can have a secondary infection because it itches and they scratch. And then you have an open door, not only for fungal infections, but for superbacterial infection. So definitely they have to change their way of treating their body. Tinea pedis, as I would say, the most common tinea infection among people. And of course, it's facilitated by wearing sneakers, which are absolutely synthetic. And that's all, again, always I say, warm, dark, and humid. Beautiful. So we have that quite often nowadays. That's just one of the conditions. I would say it's combined. It's not only that you have a little crack on the scale. You can have vesicles. That's a little bit worse condition. That's what we call pemphilis. That's Greek word, yeah. And then, 10% of total population. I would say even more. If we would be able here to check ourselves here, I would say more than 10% of the present audience, and sorry to say, would probably have positive findings for tinea pedis, or at this what we call, which is more nice to say, athletic foot, that we feel as if we are athletes. Okay, so the most common one is Trichophyton, Epidermophyton species, but the fact is that on everyday basis, it's not only something that should be treated by specialists such as dermatology. It could be, of course, in a collaboration with microbiologists after the positive findings, treated also with GPs, I would say. And then we have preventive measures, and then topical antifungus. And I would just add here, this is according to guidelines, terbinafine 1 to 2 weeks. No, I would say that 4 weeks minimum for everyone, and for any kind of cream. Why? Because the turnover is 4 weeks, and we want to cure the complete epidermis. So 4 weeks is minimum, or even longer. And of course, sometimes we have to add a little bit of systemic treatment, and these are the the recommendations for this kind of treatment. But also, it really relies on the therapist and, of course, on the person that you're talking to. Someone wants really to be cured very, very fast because he has other obligations, or he's a clumsy person, not disciplined, so he wants to, full fire at the moment, and then to cure it and then carry on probably the same way he wants. You already saw a lot of these pictures, but there are no two same nails, and there are no two same pathological nails. So that's the condition that I'm absolutely sure all of you have already seen among some of your acquaintances, friends, or even yourself. And there are certain occupations which have higher recurrence of these kind of, even among the younger people, traumatic or trauma of the nails, such as in football players because they kick, or in ballet dancers because they play on their tippy toes. Although they're very young, they can quite often have the superinfection because their nails are deformed. Trauma facilitates the infection of tinea. And of course, in elderly. I'm not going to repeat what we already heard in a very, very expanded form. So these are the treatments that are offered. And you have guidelines, but you have to look at the patient and decide yes or no. The sad thing about this whole systemic therapy about toenails is that the efficiency, that's the world statistics, doesn't go more than 60%. I would say 50. But just in the middle of your therapy, the resistance develops, and that's it. That's it. So you have to follow these patients, let's say somewhere in the middle of the treatment just to see if they're making progress or if it stays as it was, and then to decide maybe to rely only on local therapy as to prevent further spreading. That's another problem. And how do you choose the patients depending on their complete analysis of their liver and other things. Uh, that's another thing. You may use the keratinolytics and these lacquer, and then preventive measures. You've heard that already. But in treating not only nails, but I would say a local treatment for TNAP in general, I would never ever skip the Whitefield cream. It has keratolytic and it has also antifungal function. And it's a very, very old remedy, and it could be recommended as a maintenance course for further treatment of the feet, as to prevent further infections in between their toes for the rest of their life. Explain them that that's your new toothbrush and paste, the same way you treat your teeth, treat your feet. Love them. And then we have Candida. Hello, Candida. It lives with us, but sometimes it gives us a headache. Okay, so you have spontaneous Candida, and it really, ever since we are born, it may give us a headache, such as thrush, such as diaper dermatitis, but later on in life, intertrigo, onychomycosis, pyronychia, and it's not treated here, folliculitis. Even folliculitis could be attributed to Candida, and in these cases, you're very likely facing immunosuppressed people and very likely HIV positive people. In my practice, I had 2 patients, and that was the first sign of their HIV positive. Okay, so we have clinical features: superficial Candida infection, onychomycosis, oral Candida. What you have to be cautious about when giving recommendations for treatment in Candida, you shouldn't be too aggressive. You should, in a way, give efficient therapy, but also cuddle it, You should be really cautious. You should be nice to Candida. Otherwise, you can actually awaken other microorganisms that are still there, and they're in that sort of having their balance. You may disturb the microbiotic balance of the body. So you have to be really cautious. You have to be efficient, but not too aggressive. Then vulvovaginal candidiasis, quite common in different situations. Some women may have it so many times in their life, and this itching and burning, and then you should try with milder forms of therapy or recommendations. Then Candida balanitis, of course, the certain conditions such as diabetes facilitate this, using certain medications, even aggressive antibiotics. But some of these people may have it on regular basis, like every month before the period or just after the period. It really could give a lot of headache, and therefore you have to balance together with them. The feedback information is very, very important. These are the recommended topical antifungals for Candida. Systemic antifungals. Yes, in this case, I don't personally like this fluconazole 150 milligram orally. I don't like it. It doesn't cure the situation. It just decapitates the situation. We have a problem. I prefer something else. I'm talking about my own practice. I prefer fluconazole 50 milligram for a couple of days, or even prolonged, 7 days minimum, and that gives better, more stable results. But that's my own opinion. I always like to add something what is mine in my lectures, but I do rely on guidelines. Adjunctive measures. Okay, we more or less know that. And don't be surprised if someone, as a dermatologist with some experience, gives even low potency corticosteroids in these patients. It's just to diminish the inflammation, to make the field more susceptible for the real therapy, for antifungal therapy. That really helps. It's like a little bit of salt, in your soup. Soup is there, but you need just a few drops of salt to swallow it easier. And then, of course, I don't want to forget dyes. Dyes help us a lot in treatment of fungal infections, especially Candida. I would especially name here Alzine solution and Gentiana violet, and as well Castellani. I'm not going to bother you anymore, but just to remind you, that's what we say, medicina officinale, yeah, of fish. That's something that big medicines are, they everywhere in the world. It's a little bit put aside, but it's still there. Don't forget that. It sometimes really helps you. These are the real analysis from 2024, just to give you a hint how many patients, at least at our clinic in Belgrade, were suspected for and analyzed natively confirmed for fungal infections. A number, 1,000 more, 2,000 people. That's really a lot. And these are the statistics. This really proves why it's so important to pay attention to these problems. These are key messages. Be aware of common prevalent conditions considered fungal etiology. Don't overlook it. Simple cost-effective diagnosis. This native is really cheap. Refer effective treatment if prevention is key. And then I would like just few more minutes, 2 minutes of your attention. On Thursday morning, I decided to make snapshots of patients that were coming in a period of 2 hours. Believe it or not, look what we found. Case 1, pompholyx in between his toes, then small vesicles on the sole, and then also onychomycosis. Case 2, a grown-up person who was positive. They were all positive. Behind his ear, he had some scale, and even a little bit of his hair was affected. Then we will have a single in one axilla, a case of that was positive, a native positive for fungal infection. Then case 4, of course, you saw this so many times now. You know that it has to be positive. And this is a case of a young girl, and she was wearing tight sneakers because there wasn't a size that she wanted. Even her toe is sort of deformed, but look at her nail, and of course it's affected. And this was an interesting case of a lady. Her scalp was positive for fungal infection, and this red patches that she has on her face are of course negative. No, of course they're negative, and they could be considered as id reaction towards because of the presence of the fungal infection in her scalp. So this is just to give you a hint how important it is to pay attention to this kind of infection. Believe it or not, in 2 hours.
Thank you, Professor Milic, for bringing more light into the tinea world, and also to underline the benefit of officinal's product to treat
Yes.
this kind of infection.
Yes, I'm a big lover of that, and I think it will prove in future. Unfortunately, we are going very much into technology and AI and blah blah blah, but this proves how much we have to develop our own knowledge, our criticism towards everything that is offered. Don't swallow everything that is offered in the market. Be critical. Your knowledge serves you to be able to judge if something is good or not. And do not recommend everything just by literally. Thank you for bringing that.
I invite now Professor Mirjana Bakic to present the clinical spectrum of Tinea capitis in Europe, correlation with microbiological findings and therapeutic challenges. It will be online. Oh.
Dear colleagues, it's my pleasure to participate in this meeting with my topic, Clinical Spectrum of Tinea capitis in Europe, relation to microbiological findings and therapy challenges. This is the agenda. Tinea capitis is dermatophyte infection of the scalp. It is estimated 1% of all superficial fungal infections. The disease is affecting children aged 3 to 7 years old, no gender predilection, and increase has been observed in adults and the elderly. Why the topic matters now? Because rising incidence, difficult shifting agents, epidemic risk. If not diagnosed and treated properly, prevalence may reach epidemic proportions, particularly within schools and immigrant communities. There are over 14 species identified of dermatophytes. Dermatophytes are isolated worldwide, but many species are encountered only in restricted regions. The predominant organism in any area shifts over time, influenced by population movement, socioeconomic conditions, surveillance intensity, and the available antifungal armamentarium. Not every species invades here. Epidermophyton procosum and Lipophyton rhodum, common causes of skin and nail disease, do not produce true Tinea capitis. There are 3 reservoirs, 3 transmission patterns. Anthropophilic are transmitted for human to human. Most are geographically restricted, tend to drive urban outbreaks and household clusters. Many of the species arising in Europe sit in this group. Zoophilic are transmitted for animal to human, some species also restricted. Microsporum canis, cats and dogs as a reservoir, dominates much of Central and Mediterranean Europe. Geophilic species are transmitted for soil to human, generally distributed worldwide, sporadic in Tinea capitis, only 1 to 2% of cases in most European cities. In current century, there are 2 parallel epidemics. Microsporum canis continues to rise across Central and Mediterranean Europe, while UK, Belgium, Netherlands, Sweden record anthropophilic outbreaks tied to inflation. The 5 most relevant European agents are Microsporum canis is zoophilic agent dominant across Central and Mediterranean Europe. Trichophyton tonsurans, anthropophilic agent, driver of UK urban outbreaks. Trichophyton violacum, anthropophilic agent in Greece, Belgium, Sweden. Trichophyton verrucosum, zoophilic agent in cattle-associated, sporadic across rural Europe. Trichophyton sudenens, anthropophilic agent in France. The European map country-by-country pattern of causative agents shows 2 contrasting trends, 1 continent. For zoophilic belt, like Microsporum canis, it transmitted for animal to human, persistence in Mediterranean countries like Italy, Spain, Greece, Croatia. For urban anthropophilic shift, like Trichophyton consurans, violacum, in metropolitan epicenters. In Germany, over 80% are zoophilic dermatophytes. In Austria, up to 19% of cases in Graz region attributed to Microsporum canis. In Croatia, over 70% attributed to Microsporum canis. In Greece, over 80% is Microsporum canis. In France, over 14% of cases are Trichophyton tonsilans and Microsporum albinii. In UK, over 70% of Tinea capitis investigation attributed to Trichophyton tonsilans. In Sweden, in 5 children diagnosed with Tinea capitis with causative agents Trichophyton violacum, Microsporum canis. Shifting agents, while the European agent mix is changing. Microsporum canis lives in cats, dogs, and many other mammals act as endemic reservoirs. Microsporum canis tends to lose virulence after roughly 4 human-to-human passages. It is transmitted by direct human and animal contact, asymptomatic carriers, and fomites. The anthropomorphic drivers, immigration, household transmission, susceptibility and access, surveillance, variation. Clinical spectrum of Tinea capitis are different. Tinea capitis is not one disease. It presents a continuum from barely perceptible scaling to severe inflammatory disease. Widespread alopecia, localized patches of hair loss without obvious inflammation, diffuse scaling, widespread scaly downward pattern, easily mistaken for seborrheic dermatitis, black dot, endocrine infection, hair sprayed at the scalp surface, leaving black stamps, gray patch, classic ectotrix microsporum pattern, round scaly patches with shortened hairs, diffuse pustules, more inflammatory anthropophoric patterns, pustules without a defined body mass. Carrion, body, tender, inflammatory mass. Non-dermatologists continue to struggle to recognize Tinea capitis, especially the inflammatory body carrion. Consequences of misrecognition involves unnecessary surgery, diagnostic delay, permanent alopecia. The diagnosis includes next methods: scalp scrape, cytobrush, traveling toothbrush, massage hairbrush. From culture-based mycology to multiplex PCR, conventional approach is 10% potassium hydroxide microscopy, culture, and PCR, which detects and identify the major pathogenic dermatophytes from clinical specimens. The symptomatic carrier problem. Carrier is a more common with anthropophoric species. The Turkish follow-up of asymptomatic carriers found that none progressed to clinical disease. Most cleared spontaneously over 3 to 8 months. Therapy check. Mesophobia shows over 70% mean effective cure at 4 to 6 weeks. A higher dose increases cure rates. Mesophobia remains the only line Tinea capitis drug for children in the United Kingdom and remains effective against Microsporum, less so against Trichophyton. Dermatomycoses shows more susceptibility for Trichophyton tonsilans and violacum and less susceptibility for Microsporum albinii and Microsporum canis. Dermatomycoses versus Griseophorin randomized investigator-blinded multi-center international trials shows that dermatomycoses wins for Trichophyton tonsilans on Trichophyton violacum, loses to Griseophorin for Microsporum canis. Choosing therapy means identifying the organism first. The mission of public health is eradication, but eradication needs partners. For zoophilic disease, collaboration is needed between dermatologists and the vet service. For anthropobolic disease, examine and treat all household contacts simultaneously to reduce reinfection. Highly effective interdisciplinary cooperation between general practitioners, mycologists, veterinarians, and dermatologists is strongly recommended. 5 things to take away. Microsporum canis dominate Central and Mediterranean Europe. Anthropophoric species are certain in metropolitan Western and Northern Europe. Consider it in any child with scaling, alopecia, or a body scalp lesion, and in immigrants from endemic regions. A single scalp scrape is not enough. Combined scrape with cytobrush, tool brush, PCR diagnostic are on the horizon. Terbinafine for Trichophyton tonsurans, Grisopolvin still preferred for Microsporum canis. Family contacts and animal reservoirs are central to rainbow eradication. Vets and dermatologists must speak to each other. Thank you for your attention.
Thank you. It was a pre-registered presentation. We'll discuss.
There's a technical issue. If I may suggest a discussion, because we have about 15 minutes or 20 minutes for discussion. Professor from Athens, Georgia Brioni, will join us by Zoom contact
At 11.
exactly 10:30. And for
Okay.
this reason, please open the discussion.
Yes. The first two, actually three presentations are open for discussion, for questions. Please.
Yes. First of all, thank you for great presentation and big clinical experience and excellent English. My participants of this course can see that somebody from Serbia speak excellent English beside me, which is very important. Sorry for this. But regarding the medical ecology, I want to ask you one question just. Many patients which comes to our lab told us that they are already treated the nail or some part of the body, and many of them use some natural products. How is your experience? The question is for both of you, with single use of natural products, for example, essential oils, or mix it with conventional pharmaceutical products. This is the first question. And the second question, already we know that we need to brush the surface in order to get a much better sample for testing fungi. But you told that you suggested the same treatment for topical use of antifungal drugs, and this is very important, I think.
Well, first, thank you for your questions and especially for, yes, your attention that you gave me while presenting. Let's say, let me see, the first question, it really relies on my remark about the Medicina Officinale. And that means that we shouldn't be really too proud and stubborn that the human beings live here on this earth for, let's say, range of 5,000 years. So they were treating different kinds of diseases in different ways, and different cultures have different approaches. So it's not that we only know the truth. And I would say that not only concerning the mycology, There are certain, we call them traditional medicines that could really help, Of course, there are certain people who know the ingredients of certain plants and so on. But of course, you should be, you as a therapist sometimes you have to go into this different field, you inform yourself at least few things to know in which direction to go. Like they could give this anti-inflammatory support sometimes. That's the whole different thing. I'm not absolutely against, but I would say go and buy something yourself. They have to be. They have to be also in a way consulted with someone who knows. And just to remind you, the whole let's say this medicine that we're talking about, or pharmacology, it all comes from the nature. Even the fungus, they come from the nature. And of course, some of fungus help us. Don't forget penicillin. And don't forget that in the First World War, during the First World War, some German soldiers would use the rotten bread to put on their wounds to help them heal. So I wouldn't say I would absolutely rely on one or the other. I like these combinations, but that requires more time of us as therapists to know what we're talking about. It's not only that, let's go, I'm sorry, just 1 minute, one more remark. For viral infections, you don't have a remedy insufficient. So you sometimes have to rely on these, what we say, things coming from, no. Arnica, for instance, arnica. Arnica, it really suppresses, and it's present all over Europe, it suppresses, it helps in inflammation. Arnica. So, why not? But not completely, not left, not right, somewhere in between. And the second question was
Pre-treatment.
pre-treatment. Yes, definitely. You facilitate the thing, clean it. Get rid of greasy things. And dirt. Greasy things and dirt. Don't overdo it. Some people do that, but you have to do it. Even for the versicle, you have to wash yourself out. Sometimes because it affects the superficial layers. A good thorough rubbing and scrubbing could be absolutely sufficient. Not even any kind of remedy. Just rub and scrub. Right? Chop off the layers that are affected. And I'm sorry, it was too much. Okay. I hope we have time. Okay.
We don't have enough time because at 9:45, Georgia will start the presentation.
Okay. We have 2 more minutes for the meal.
But also after.
What is the percent?
Quarter after 10.
Or 10:15.
10,
10
15.
past.
Yeah.
10 past.
Quarter after
Sorry,
10.
10 past.
Yeah, time for Danielle.
Yeah.
Yes.
Well, thank you for your question. I would like to be short because I can use the time. Regarding the first question, natural remedies in dealing with treating patients who are onychomycosis or all kind, I do have an experience that my patients and those of the patients using tea tree oil trials.
Yeah.
Tea tree oil is considered to be very important antimicrobial. However, if applied only as a medication, it is in practice insufficient. So we have to add some kind of washing with antimicrotic, like micronazole or whatever. So it has the sense that we have the superficial TNF. It's superficial fungal infection. Regarding deep, carrying cells, like absolutely effective. The tea tree oil can only control the superficial of the skin show the infection. According to my experience, cannot cure the patient. This is the first kind of natural remedies in infection of the skin and nails, especially. Oregano as well. Oregano and tea tree oil are the most people natural remedies that I avoided according to my experience. And the second question, pre-treatment of patients is very common. So it's harder for the microbiologist to identify the area. Multiple steps, 1, 2, 3, 4. For instance, for nails or for pre-treated patients, use multiple steps. Therefore, this is how we can overcome the problem of negative false cultures, false negatives. Exactly. That's also false. So,
Based on
contaminants are a separate problem. So we have that problem. So we have multiple slabs in order to identify the agent. So the problem for antimicrosis is to identify two different. And the second, what is the problem? That we do not have powerful tools. According to the literature, in the world, there are drilling techniques. So you destroy a little bit, or they make like a small drill. So you just make a small hole, and then you dig out your microbiome. In this case, could be a dermatomycoses, this could be more. And what I see as a problem in the future, and this is epidemiological for me, I would say alarming, that more and more patients are going to have mold infections. Not only TINA, but everywhere. So we have a practice that biologics are involved. This is the era of biologics in the medicine. So use biological therapy. We have psoriasis, no, we're not going to treat the way we used to treat more. Now you're going to have biologic. You have, I don't know, what you have on the lungs or even cancer, you have also biologic. You have inflammatory bowel disease, you're going to have we have two kinds of problems. These are resistant form of tuberculosis, which is exploding. And now, according to the data we were comparing the previous years, there are 30% de novo diagnostic tuberculosis in, for instance, Serbia than in previous years. And this is also, we know that this is a silent problem that is under, so it's not fashionable to talk about that problem. We have a problem of the molds, and this is what we speak about.
Thank you.
Biology, the era of biologics will, let's say, the problem.
Thank you. We try to connect Georgia. Hi, Georgia.
Good morning. How are you?
Welcome to the morning session.
It is
Pleasure to see you.
Mikhail.
Yes, I am.
Is you Mikhail? Nice to meet you.
Nice to meet you too, even online. Yes, please. You
Yes.
have half an hour to present the lecture. Please.
Can I share the presentation?
Yes, please.
So let me share it.
Share the screen.
Yes, just a moment. Just a moment to make them full screen. Yes. So share. Share. It is okay, Mikhail?
Not yet. Now it's okay. It's okay. You can start.
It's okay?
Yeah.
Please. Oh, sorry.
Now it's okay.
It's okay, yeah?
Yes, we are seeing.
And also,
Everything will be okay.
I can't move it. Sorry. Sorry for the delay. It is okay?
Yes, yes, it's working.
Okay. So, thank you very much for the invitation. I'm terribly sorry that I'm not with you in Belgrade, but I must be here in Athens, so good morning from Athens. And my lecture is about onychomycosis and diagnosis in Balkan region and everywhere. So, onychomycosis, as we know, is a fungal infection of the fingernails or two nails. It's a chronic disease with a tendency to relapse, with a worldwide prevalence of 5.5% and estimated prevalence of 2 to 14% in the US, 0.5% to 24% in Europe, with different pathogenic organisms, and the first ones are dermatophytes, and especially Trichophyton rubrum, 90% in two nails. And the name of onychomycosis is Tinea unguim, if it's due to dermatophytes. Non-dermatophytes molds, as Scopulariopsis brevicolis, are opportunistic pathogens after injury for 10% to 20 to 30% of onychomycosis, and also yeasts 10 to 20%, especially Candida, like Candida albicans, more frequently in the fingernails if the hands are routinely submerged in water, and in patients with chronic mucocutaneous candidiasis, immunologic disorders, and diabetes mellitus. In these slides, you can see the classification of onychomycosis is a modified classification of Zayas by Hay and Baran, distal and lateral subganual onychomycosis, white superficial, proximal, endonyx, total dystrophic, and also candidal onychomycosis, and also the secondary onychomycosis due to psoriasis or other diseases. The first causes are dermatophytes, especially Trichophyton rubrum, but also Trichophyton metagrophitous complex, and especially Trichophyton interdigitale. And as you see here, except Trichophyton, also Epidermophyton flocosum can cause onychomycosis, but not microspore. As regards non-dermatophyte molds, we have Scopulariopsis brevicolis, different species of Acremonium, Fusaria, Aspergillus, Neositalidium, and also Onychocola canadensis. And as regards yeasts, we have especially Candida albicans, and as regards Candida non-albicans, especially Candida parapsilosis. In these slides, you can see an epidemiology study of onychomycosis from Athens, and especially a retrospective analysis for 4 years from Hospital Andreas Sigros, is a reference hospital for different tinea, but also for STIs. So here you can see that we have Trichophyton rubrum as the most frequent dermatophyte, isolated in most of the cases. The second one, Candida albicans, among the yeasts, and as regarding NDMs, Acremonium, Fusaria, and Aspergillus. What about laboratory diagnosis? First one, if we want to do an accurate diagnosis of onychomycosis, we need the history of the patients. Age, shoe type, repetitive injuries, genetic predispositions, underlying diseases like psoriasis, diabetes mellitus, circulatory disorders, or immunosuppression. And be careful, 1/3 of onychomycosis cases are together with tinea pedis. Except gender, age, and occupation, also we need to know the location of the lesions, the clinical picture, also previous local or systemic treatment, nationality and country of origin, and also residence or recent travel abroad. The patient's country of origin is very important for the diagnosis, especially if he comes from or has visited tropical countries where specific exotic fungi are endemic. What about clinical picture? Clinical picture sometimes of onychomycosis can be with the organisms that are most commonly associated. For example, if we have a distant lateral subungual onychomycosis, most commonly associated organisms are dermatophytes and candida. Also, if we have, for example, a totally dystrophic onychomycosis, except of dermatophytes, also may the cause be a candida albicans. And if we have a paronychia with or without onychomycosis, candida is the main cause. Very important for the diagnosis is the specimen collection. The sample should be collected from a selected site of the lesion under aseptic conditions. When there is more than one location, the sample should be taken separately from its location. If possible, before starting of treatment, the sample quantity must be sufficient to carry out microscopic examination and culture. In case of treatment, therapy must be discontinued for a period of time depending on the previous treatment so that the fungus can be cultured, and also nails must be uncut and untreated for 1 month and unpainted at least for 3 days. How we take the sample? We use scrapings from the subungual at the border between the health and the affected part of the nail with an anatomical knife after cleaning with 70% of alcohol. Very important this one, and also very important to take the sample at the border. It is the way that we take something that is viable and we see the fungus if there is in culture. Also scrapings from the surface of part of the affected nail, and the collection must be done in a plate or with a swab with saline, especially if we have also a paronychia. Small and medium-sized scrambled partially 3-ply subungual and nail clippings at the transition between diseased and healthy tissue represent the optimal material for mycological evaluation, and alternative, we can use electric nail threads. And here you can see how we do the microbiological laboratory diagnosis. First of all, we have microscopic examination, culture, and also we use multitool for the identification, and also new methodologies. Very important that do not forget the potassium hydroxide examination using 20% KOH, and represents the simplest method but with an insufficient diagnostic sensitivity in onychomycosis 40 to 68%. If we have a fluorescent microscopy, fluorescent stain, it's very useful. It is the most sensitive method. In these slides, you can see also without stain, with lactofen blue, and also with fluorescent stain, and how we can see the height of the fungus. Here, without staining, we can see height that cross over more than one cell and are branching here. And also be careful about branching mosaic pattern that presents the juncture of normal epidermal cells. What about diagnosis of Candida? This you can see the microscopic examination. You can see blastoconidia and also pseudohyphae using 20 to 30% KOH. What we use About culture media, we use saborodextrose agar plus saborodextrose agar containing cycloheximide to suppress mold growth. Sometimes, if we have dermatophyte test medium and also culture media for sporogonia. Be careful about the cultures. Cultures are incubated at a temperature for 26 to 32 degrees, optimally at 28 for 3 to 4 weeks. And we visually check for fungal growth twice weekly. If a slow-growing dermatophyte is suspected, like a Trichophyton violaceum, the incubation period should be extended to at least 4, better 5 to 6 weeks. Cycloheximide allows for selective growth of dermatophytes, but one has to bear in mind throughout that despite the inhibitor, some molds are still capable of growing on this agar. What about Candida? We use also saborodextrose agar, and the identification is very easy if we use a from agar, biochemical properties, production of characteristic carnidospore, and also germ tube test that we have pseudohyphae different if we have Candida albicans or Candida tropicalis. What about the identification of molds? We use microscopic features and microscopic features. As a microscopic feature, we can see the anterior and the posterior surface of the colony, diffusion of the dye in the culture media, surface and structure of the colony. Also, as microscopic features, we observed of a section of the colony with lactophenol blue to identify macro and microconidia with a fresh preparation and the zelotape test. And as you all know, fungal culture are the gold standard in mycologic diagnostics, but are still time-consuming with results taking 2 to 4 weeks to come back. That's why we have also PCR and real-time PCR, as well as multitoph MS for the identification of the fungus. As regards molecular biology and detection of fungi, we have various methodologies, uniplex PCR, but especially multiplex PCR for simultaneous amplification of multiple mycotic pathogens like dermatophytes, yeasts, and molds, as well as real-time PCR. Here you can see a Trichophyton specific or pandermatophyte multiplex PCR kit that used 2 different primers. Chitin synthetase 1 for detecting dermatophytes and internal transcriber spacer 2 primer for detecting Trichophyton rubrum. The test is completed with 5 hours, including the extraction stage, and the analysis is made after that with an electrophoresis with ethidium bromide. And as you see, we have 2 positive controls, one from Trichophyton rubrum, the other pandermatophyte, and also an internal control. And as you see in the pictures, samples 4, 5, 8, and 9 are positive for Trichophyton rubrum, but 2, 6, 7, and 10 general for dermatophytes, non-Trichophyton rubrum. We have evaluated this PCR test, and by using this PCR assay, the number of positive specimens was increased by 7%. Furthermore, the percentage of those with a specific identification, Trichophyton rubrum or dermatophytes, was increased by approximately 12%. So we propose an algorithm. First of all, microscopy. If this is positive, culture. If this is negative, a PCR. If this PCR is positive, so we have a dermatophyte infection. If PCR is negative, so we need a new sample because we have a positive microscopy. If the microscopy is negative and culture is negative. So if we have the clinical picture of onychomycosis, we need to do a PCR. If it's positive, a dermatophyte infection is okay, but if negative, no onychomycosis. If culture is positive, so if it is a dermatophyte, so we have a dermatophyte infection. If it's a non-dermatophyte molds or candida, so we need a new sample. Another multiplex real-time PCR for pathonostic is very useful one. There is we have two kits, a nail multiplex assay for Candida albicans, Trichophyton rubrum, and Digitalia, and a second kit, a complete multiplex kit, not only for nails but also for skin and hair, that detects Candida albicans, different Trichophyton, also Microsporum, and Epidermophyton floccosum. This kit gives the possibility of detection of two pathogens in mixed infection. Also, the results, we have the results within 3 hours, and also with higher sensitivity. We differentiate different dermatophyte species, and also we have the identification of source of infection in case of outbreak management. This kit uses melting curve analysis to differentiate the different types of dermatophytes, and in a retrospective study of 138 fingers and 2 nails clippings from patients with suspected onychomycosis, this kit gives excellent sensitivity and specificity in comparison to histology and culture methods, and with real-time PCR, we can unmask the presence of no-growing fungal pathogens, and also better identification and shortens the time to diagnosis. 2 other kits from Eurobio, and Eurobioplex dermatyping RUO1 that differentiate not also Microspora but Trichophyta. Inside we have also Trichophyto indotineae, Epidermophyto floccosum, excellent clinical and sensitivity and specificity, and also another version. This one is CIVD1, Europlex Derma Screen, different types of Trichophyton, Candida albicans, Parapsilosis, and Scopulariopsis brevicolis. So, with molecular methods, we have some advantages. This method closes the diagnostic gap left by microscopy and culture, and increases the sensitivity and specificity of mycologic diagnostics, and shortens the time to diagnostics. But we have also disadvantages. The method entails high personnel and equipment costs. Results of the info-PCR have to be critically scrutinized, because false negative results do occur, especially as a result of inhomogeneous distribution of dermatophyte DNA in nail material. So, conventional techniques, microscopy and culture, should be supplemented and not replaced by molecular detection methods. What about multitoph-Ebes? This method is based on protein mass fingerprint or mass spectrum. It's a very culture confirmation test in the differentiation of dermatophytes, non-dermatophyte molds, and yeasts, and give the results in 5 to 7 minutes in a very good manner, like a molecular method. Here you can see different examples of spectra of various dermatophytes. So, some useful tips for the diagnosis of onychomycosis. If we have a candida, is a causative organism in finger leaves, but if it isolates in 2 nails per culture, perhaps it's a colonizing and hiding Trichophyto rubrum. What about the evaluation of non-dermatophyte molds? Repeat culture, if it's positive, also with the same fungus, take a history of patients and perhaps a new sample. Non-dermatophyte molds give a positive microscopic examination. Yes, if you can see better in these slides, there is in this direct microscopy hyphae regularly septate, and from some species like Aspergillus niger, also with Aspergillus niger you can see in microscopy black conidia, Aspergillus candidus, Acremonium, Fusaria. Is possible infection from two different dermatophyte species? Yes, you can see here a petri dish, anterior and posterior, with two different Trichophyto interdigitale and Trichophyto rubrum from the same patients. If Trichophyto rubrum is found on finger labes, look it on two nails as well. Perhaps overgrowth of other organisms, for example bacteria, may mask the real pathogens, so we need a good cleaning of the nail and a disinfection with ethanol 70%. Also evaluate culture if Pseudomonas aeruginosa grows. We must differentiate yeast. Here in this plate you can see also colonies from Candida albicans and Trichosporum cutaneum. And also, we must do the differentiation Trichophytum from Chrysosporium. You can see also the culture and a microscopic examination. So, what about the evaluation of microscopic and culture results? When a dermatophyte is isolated, it is always considered as the pathogenic cause of onychomycosis. The diagnosis of yeast and NDMs as causes is made when fungal elements, Blastoconidia, hyphae, are found in direct microscopy of the clinical specimens, and for the diagnosis of NDM infection, the same fungus must be isolated in at least 5 of the 20 colonies on plate. If we have a non-dermatophyte mold and we must to give an answer for the onychomycosis, we must have also a positive direct microscopy. Positive culture also be careful in the choice of culture media because sometimes may inhibit NDMs. Also, we must exclude of dermatophyte as the cause of onychomycosis according to the criteria of Walsh and English. Repeated sampling and isolation of the same fungus in at least 2 different cultures. Colony must be counted. Isolation of the same fungus in more than 5 colonies is required. And also, much helpful are histopathological techniques and molecular methods. What about the criteria of Walsh and English? This criteria, there is in this very old publication in 1966, and as you see, if you have a Trichophyto rubrum infection, this is an infection of many nails at the same time. The area of infection is deeper in the inner layer of the nail. There is a rare presence of Leukonychia trichophytica, and also we have common contoured skin infection by the same fungus. Also, we have an association of infection with age under 50 years old with young patients, and also a rare concomitant non-mycotic skin disease. So, all we know that Trichophyto rubrum is an organism well adapted to a pathogenic role. So, in the end, onychomycosis diagnosis across Balkan and also all over the world. Be careful to obtain a good clinical sample. Microscopic examination with KOH is essential. Also, culture must be carried out under the right conditions. Multitoph spectrometry technique offers great help in correct identification, and molecular techniques for detecting genetic material are complementary to the conventional ones, especially in case of previous drug treatment. And before I finish, I want to introduce the mycology team in Athens, in medical school, except me, Associate Professor Kelly Theodoridou, three technicians, Dora Koliou, Stavroula Kritikou and Aphrodite Pilioni, and two secretary, Marina Koliou and Mara Vakla. And thank you very much, and I hope to see you all all of you in Balkan Fungus 2026 in October in Cluj, Mikhail. Okay, thank you very much.
Thank you so much, Georgia, for your excellent talk and for pointing out a few essential details for the laboratory diagnosis of onychomycosis. Please stay with us for a few more minutes because we'll have some questions from the audience. Please, we can retake questions. Yes, please.
I don't know if you hear me, or should I stand
I
up
think
also?
we'll use the microphone.
Well, good morning. Thank you for excellent presentation. Do you hear me? Excuse me. No?
Sorry, Mikhail, I'm not hearing.
Yeah, I think you can use direction.
Good morning. Do you hear me now?
Yes, please. Good morning.
Thank you for your Thank you for excellent presentation. It encompasses all the data we need. I'm a clinician. I work at a university clinic in Belgrade, and I'm full-time professor of dermatology in Belgrade. My question is would be related to the diagnostics of the fungal infection, because in everyday life, the diagnostic is not 100%. For instance, if we have native swabs and so on. The sensitivity, as you have mentioned, of the fluorescence staining is much greater, of course. And this is, for us, very important to start the treatment, to follow up the patient, and at the end to see if the patient is cured. But we do not have fluorescence staining. So how is the situation in Athens? I mean, how it is accessible to your doctors? Is it used in everyday practice or from a time to time in different institution or academic institution? This is very important for us. And thank you for your answer. Sorry.
So, thank you for the question. So, in Andreas Sigros, that is a reference lab for not only for STIs but also for fungal infections. We use for onychomycosis. We use appointments because it is not very easy to have the time to see all the microscopy, and we need some time. So we use appointments for the patients. They have some not to treat not to clean the nails and come to the lab, and we take the laboratory take the specimens, and first of all we do direct microscopy. Also, sometimes we use fluorescent with Placophorpep because we have the microscopy, the fluorescent microscopy to do that. And if the culture, and if we have difficulty to the diagnosis, sometimes we use PCR. But not always, because it's not very easy to do to everyone PCR. And for the identification, we use the classic way, and also multitoph MS. We have two different multitoph MS, one Bruker and the other Otobio, because the second one in the library there is also Trichophytoindotineae, because we are endemic in Greece with Trichophytoindotineae.
Thank you, Georgia. Other questions for Professor Brioni? If not, thank you again.
Thank you very much, and I see you in Cluj, okay, Mikhail?
Yes, sure. Thank you. Bye.
Bye.
We can continue with question for the previous speakers if you have more questions. No. So everything is clear. We would like to thank to the speakers for their excellent presentation and to all of you for attending this session. Thank you very much.
Stressful when we have this technical issue. Everything